All right, so I'm going to be giving this talk, but just so you know, there's a nice article, I'm certainly biased since I wrote it, in Radiographics discussing this entity. Topic you wouldn't think is that interesting or exciting, but it's already had 60,000 downloads. Same disclosures not related to this presentation. So my goal during this talk is for you to be able to distinguish between the different common pancreatic cystic lesions, to identify features that are more commonly associated with malignancy, to select guidelines that are relevant to your reports, and to integrate what's referred to, as you'll see, the concept of the field defect related to pancreatic cysts into your practice. As you all know, with more frequent and improved imaging techniques, whether it's CT, MR, or ultrasound, it's led to greater detection of these pancreatic cysts. They're seen in approximately 10% of the population and up to 30% when patients are over 70 years old. This is the classic incidentaloma, as Perry had alluded to. These are seen on MR, especially when we do T2-weighted images. It says 20 to 44% of patients. I certainly diagnose it quite often when I'm reading MRs. I rarely diagnose on CT. I don't know which is better. We could talk about that certainly, but you see them easily on MR. You could certainly see them on CT as well. And the vast majority of these are benign. So to break down the different cystic pancreatic lesions, there's the benign lesions, whether it's a pseudocyst or a lot of what we used to call pseudocysts is actually referred to as wall-duct necrosis because it's felt to develop from necrotizing pancreatitis. There's serous cystadenomas. The potentially malignant ones include mucinous cystic neoplasms, as we'll talk about, and the branch duct IPMNs. And the frankly malignant ones are the solid pseudopapillary neoplasms, the pancreatic neuroendocrine tumors, and the ductal adenocarcinomas, although the solid pseudopapillary is not as malignant as the other ones, certainly. So what are the key features that we want to look at? Well, we want to look at the size of the lesion. We want to look at the number and size of the cysts and the septa. We want to look if there's a thick enhancing wall, and I think that's important because it changes their differential. If there's nodules, and certainly the relationship to the main pancreatic duct and if the main pancreatic duct appears abnormal. We also want to look, as I mentioned, the dilatation of the main pancreatic duct. And I think that's become more and more important, at least in my mind. So when we look at a pancreatic cystic lesion, the first thing you want to do is you want to see, does it communicate with the pancreatic duct? Because that limits your differential to branch duct IPMNs or related to pancreatitis, whether it's dilated side branches or pseudocysts / wall-duct necrosis. And I'll discuss the guidelines at the end of this talk. Many of these small cystic lesions do not appear to communicate, but we still presume that they're probably, especially when they're small, branch duct IPMNs, and we follow them as branch duct IPMNs without necessarily requiring aspiration. Features that certainly suggest malignancy in the setting of a pancreatic cystic lesion: if you have an internal enhancing solid component, if you have a thick enhancing wall, as we talked about, that could be a neuroendocrine tumor, but I've also seen it in adenocarcinoma, but that differs from branch duct IPMNs generally. And sometimes MR can be helpful. A lot of times it doesn't change your differential, but sometimes it can show the complexity. Certainly if there's hemorrhage, nodules, and septa, better than CT. Diffusion-weighted imaging we thought was going to be helpful, and it can be helpful, but unfortunately it doesn't differentiate the different types of cystic lesions, nor ensure if they're malignant. So when do we consider pseudocyst or wall-duct necrosis? Well, that we consider in the setting of acute or chronic pancreatitis, if there's features of pancreatitis, or if the patient had a history or imaging or clinical findings suggestive of pancreatitis. If they're symptomatic, certainly they can be aspirated or resected. Here's an example of these fluid collections. We used to call these pseudocysts, but a lot of these, as I mentioned, especially when they arise from the pancreas, are actually due to wall-duct necrosis. So this same patient, it was a 36-year-old male. Interestingly enough, he had debris within the fluid collection, again favoring wall-duct necrosis and suggesting that it's not a mucinous cystic neoplasm. And that was something that Dr. McCarry, who unfortunately is no longer with us, had written up years ago. So what's the most likely diagnosis here? Is it A, adeno, B, mucinous, C, endocrine, or D, serous cystadenoma? Well, we have a lesion on CT. It looks somewhat solid, right? It's enhancing or appears to be more solid. With the MR, we nicely can see that it's predominantly cystic. It's multilobulated. It's got small cysts. In fact, it has a central low signal area, probably a scar. And this turned out to be, as suspected, a serous cystadenoma. What are serous cystadenomas or microcystic adenomas? I always remember there was a resident a few years ahead of me. She used to call this the Tiffany lesion. And why did she call that? Because she said good things come in small packages. So it's a benign tumor. It has multiple small cysts accounting for the Tiffany lesion, with the cyst being less than 2 centimeters, generally in older women. But it can be seen in men as well. It has that honeycomb appearance, as we mentioned, with these innumerable variable size cysts. Another feature that I like is this multilobulated appearance with external lobulations, which isn't emphasized, at least in the literature, but it suggests to me that it's going to be a serous cystadenoma. And radiologists can often confidently, these are the ones that we can confidently diagnose, especially when it has a characteristic imaging appearance. And the key feature is that these are non-surgical lesions. As we mentioned before, sometimes with CT, they can look solid. And why does it look solid? Because you got all those multiple septa. They're all enhancing, making it look solid, that high stromal content and that honeycomb appearance. On the MR, you could better appreciate sometimes the cystic component and the multilobulation and the central scar. And again, pathology is what you want to correlate with. You can nicely see, this is an example where you can see a central scar with multiple small cystic lesions. At AFIP, now ARP, they used to say this is a corresponding image when you're not sure it's the same exact image, but this one is actually the same patient. But in any case, this looks more solid because of that multiple septations. What about mucinous cystic neoplasms? Well, mucinous cystic neoplasms are the ones that you want to be careful about because they can mimic pseudocysts. But the key feature is that these patients don't have a history of pancreatitis. It's nearly exclusively in women, classically middle-aged, and that's important. That's where demographics is important because they're essentially case reports in males. So if I have a male with a cystic lesion that looks like a mucinous cystic neoplasm, often it's not because these have ovarian-like stroma. These, as you would expect, contain mucin. They don't communicate with the pancreatic duct, unlike IPMNs. 95% of them are in the body and tail of the pancreas. And again, the key feature as imagers is that these are few and large cysts. They may have nodularity from the papillary projections. They may have a solid component, but again, they don't have a history of pancreatitis. So this looks fairly innocuous, fairly benign. Looks like a pseudocyst or walled-off necrosis, but the key feature here is the patient did not have any history of pancreatitis. So generally, these are resected because they're malignant potential. Mucinous cystic neoplasms can develop into or have invasive adenocarcinoma. It's been reported as 10 to 17%. What are the risk factors? Advanced age, a large tumor size, if you start to see more irregularity and thickening, and certainly if you start to see enhancing masses or mural nodules, and obviously if you have nodal and distant metastases, these often have a high CEA. You can see that this is a complex mass with some high signal within it and enhancing septa, and on pathology, this was a malignant mucinous cystic neoplasm. Just a nice comparison. Again, I don't rely on the age, but this is classically the one that is referred to as the mother tumor, mucinous cystic neoplasm 40 to 60, while serous is more commonly in older, but obviously you can see serous in males as well as in younger patients. More importantly, in my opinion, is that these have few cysts, large cysts, as opposed to this where it tends to be multiple cysts and small cysts, although occasionally you can have a large cyst as well here. Obviously, you have mucinous fluid in the setting of mucinous cystadenoma, while this has glycogen. And if you have calcifications, the mucinous tends to be peripheral, while the serous tend to be more central. And importantly, these are the ones that are malignant and tend to be surgical. These are non-malignant, tend to be non-surgical, although some institutions will operate when the patient's younger with the argument that they want to catch it when it's smaller. But again, that's up for debate. This is a 20-year-old female who had abdominal pain. Once you notice these fluid levels from hemorrhage, it limits your differential. In a young patient like this with a large tumor or large lesion, no mets, no other findings, this is going to be a solid pseudopapillary neoplasm. We used to call these SPEN or solid papillary epithelial neoplasm, but the bottom line is that these are the lesions that have hemorrhage. They tend to be large. They tend to be in younger patients, although I have seen in older patients as well. These are low-grade malignancies. As I mentioned, this is the one they refer to as a daughter lesion. But again, I would base it based on the imaging appearance, which is these are large encapsulated lesions. They can be solid, mixed solid, and cystic or cystic, depending on the degree of hemorrhage and necrosis. And MR sometimes can be helpful because it shows the presence of high signal intensity, as I'll show you, differentiating from other causes. So this is an example. This is a patient who was pregnant, had imaging before pregnancy. This was done obviously after pregnancy, or maybe not obviously, but we gave gadolinium. But the key feature here was that there is high signal intensity on the T1 fat suppressed images. This is due to a SPEN, or solid pseudopapillary neoplasm, as it's now referred to. This is something where I learned from, because I always thought, oh, you have a solid pseudopapillary neoplasm, they're locally aggressive, you don't have to worry about them so much. But here's a CT scan. This was lent to me by one of my former residents, and Dr. Thacker. But it nicely illustrates the person had resection of the pancreatic head mass, and then 2 years later, unfortunately, developed liver metastases. And liver and metastases can be seen in 4.4 to 9%, most often in the liver, rarely lymph nodes, peritoneum, or lung. And I've seen it several times since then. Again, demographics are great for these kind of lectures. They're useful, but again, it shouldn't be the main feature that you look at. In residency, we all learned that SPN is a daughter lesion, and Mucinous cystic neoplasm is a mother lesion, and Serous cystadenoma is a grandmother lesion. But again, I think the overlap sometimes limits the utility, even though I have fun using it. It's most helpful to realize, however, that Mucinous cystic neoplasms are seen in females and not in males, as we talked about. And some of the other entities can certainly have overlap. What about this lesion? Well, it's right on T2. You might call it just the usual cystic lesion, an IPMN. But then when you look closely, you see that there's ring enhancement. And once I start to see ring enhancement, I start to worry. In this case, it was due to pancreatic neuroendocrine tumor, which is probably the more common cause of that. And these are important to diagnose because of their malignant potential, so you want to look closely at the cyst wall. Another example showing a thickened wall, some nodularity, and again, this was a neuroendocrine tumor. This brings me to, similar to the liver tuck, my mimickers section. How many of you think this is well-depth necrosis or a pseudocyst? Raise your hand. How many think it's a mucinous cystic neoplasm? How many's given up on me and are not voting? This is an example of well-depth necrosis. How about this one? Well-depth necrosis or pseudocyst, mucinous cystic neoplasm. This is a mucinous cystic neoplasm. And last but not least, well-depth necrosis or pseudocyst, mucinous cystic neoplasm. This was tuberculosis, sorry. So again, I like this slide. I had my illustrator make this years ago. As you can see, you're confused. You're wondering which way you should go. So the way I think of it, if you have and I didn't give you the history, unfortunately, but if you have a cystic mass in a patient with pancreatitis, it's more likely going to be well-depth necrosis or a pseudocyst. In contrast, if you have a cystic mass without pancreatitis, you need to consider other etiologies, such as a mucinous cystic neoplasm in the right demographics, being a female. You want to look for communication with the pancreatic duct to suggest it's an IPMN, but certainly consider fine needle aspiration if you're not certain of the diagnosis. What about this example? So we have a lesion in the pancreas. It's dark on T1. It's bright on T2. If you look really closely, you see some low signal intensity. How many of you would aspirate this lesion? What would happen if you aspirate it? Obviously, it's a loaded question. It used to be a Fireside, with filling, and it was a mosquito, but I think since it's being taped, I had my illustrator make this. He's drilling for water and he hits gas. Why did he hit gas? Because it's a pseudoaneurysm. So again, if you have a cystic lesion, you want to make sure it's cystic, either do color Doppler or do contrast-enhanced CT or MR to ensure that it's not a pseudoaneurysm. How about this one? Well, here's an example. This was a 53-year-old, had a history of pancreatitis, was thought to be well-depth necrosis. Unfortunately, when you look closer, there's a solid component. There's some nodularity. You can even see, in fact, that they drained it thinking that it was well-depth necrosis. This actually was a cancer that arose in IPMN. So you really have to be careful sometimes, and it's kind of scary. Your clue also might have been that the pancreatic duct itself is dilated and leading into the cystic mass. But that could be seen, obviously, in the setting of pancreatitis as well. So what are IPMNs? IPMNs are a spectrum of cystic lesions. They're mucin-producing, leading to either main or branch duct dilatation. They're usually asymptomatic. We used to think that they're rare, but in my opinion, these are the more common cystic lesions that we're seeing. I said 20 to 30% of cystic lesions, but I think it's significantly more, generally in older patients. And unlike other cystic tumors, the nice thing is that you often see and should look for communication with the pancreatic duct, and you want to distinguish these from pseudocysts. What are the features that we worry about? The features that we worry about for malignancy include if we see a mural nodule, if we see wall thickening, if we see main pancreatic duct dilatation. That's a key feature that we worry about. But these can be challenging even for experts because the benign and malignant IPMNs can often look similar, and it's hard to predict, in fact, which ones are going to become malignant, and that's our biggest challenge. So we need to better define the extent of follow-up needed, perhaps based on clinical or imaging features. Otherwise, obviously, we're going to bankrupt our healthcare system. So what are the branch duct IPMNs? Well, sometimes I find that people call these serous cystadenomas, especially when you see it in the uncinate, because it looks like a cluster of grapes. But the uncinate lesions, a lot of times you'll see actual communication with the pancreatic duct, and these are due to branch duct IPMNs. And MR and MRCP can be helpful because sometimes you can actually see that communication, and it's a slow progression from hyperplasia to low-grade dysplasia, high-grade dysplasia, and developing into cancer. In contrast, the main duct IPMNs, I want to spend more time focusing on that. I want to see if the main duct is dilated because those are the ones that have a higher risk of malignancy, and we need to closely assess those. So here's an example of a dilated main pancreatic duct. Somebody might think it's chronic pancreatitis. When you look closely, however, you see that there's a mural nodule, and sometimes these can be really hard to see whether you're doing MR, CT, or ultrasound. But in this case, you could see that there was an enhancing nodule, and this was a tumor arising in a main duct IPMN. Another example, this is dates back to my fellowship, but it's a great case. You could barely see the pancreas. You could see the largely dilated main pancreatic duct. You can actually even see that bulging ampulla, which is what they see, the fish mouth opening that they see on a ERCP where the mucin pours out of the duct, and that's what you want to look for. What's the extent of the problem? Well, if you read the literature, and these figures may be even too high, but branch duct anywhere from 3 to 15% develop into malignancy. And again, I think that's an overestimate. The main duct certainly has a higher risk of malignancy, and this too may be an overestimate, but the literature quotes anywhere from 31 to 45%. What do you want to do? Well, it's interesting. When you read the literature, the surgeons and the gastroenterologists, I think it's important for us to use the same lingo or at least be aware of the lingo. They break it down into worrisome features and high-risk stigmata, with high-risk stigmata being surgical. And I always have to reinforce this because it's hard to remember. But basically, the worrisome features are the cysts that are over 3 centimeters, if you have a thick enhancing cystic wall, if you have non-enhancing mural nodule, if the main duct is anywhere from 5 to 9 millimeters, or if there's regional lymphadenopathy. In contrast, the high-risk stigmata are the obstructed common bile duct. So certainly if a patient has jaundice with a pancreatic head lesion, if there's an enhancing mural nodule, and again, if the main pancreatic duct is over 10 millimeters, because 10 millimeters you usually don't see in the setting of chronic pancreatitis or just ectasia of aging in the absence of a cause of obstruction. So again, here's examples of main duct IPMNs with a solid mural component, an enhancing component. This is a cancer developing in the setting of a main duct IPMN. But you want to look closely. So here's an example on CT scan. You can see that barely that there's an abnormality. MR, if you look really closely, you can see there's actually, in fact, a low signal intensity nodule. And in fact, that nodule is enhancing. So this was a patient who had a main duct IPMN with an enhancing adenocarcinoma. And sometimes, certainly we recommend EUS, and you can see why, because on the EUS, they could clearly see that presence of that mural nodule, and they can, in fact, biopsy the mural nodule to show that it is due to cancer. This was a patient, and it begs the question, why do we keep imaging other than I could show this in my talks? But this was 2008. There's probably images after 2013, but you could see that there's a mural nodule. The mural nodule every year is being imaged. It's growing. This is cancer developing in an IPMN, nicely illustrated. Sometimes, as illustrated here, that they could be fairly non-aggressive, I guess is the correct term, because, this is over 5 years, and like I said, they've been following them even since. What about main duct IPMNs? As I mentioned, it's often difficult to see these small mucin-producing nodules. The guidelines certainly differ regarding the size of the main pancreatic duct. The Fukuoka guidelines, which are probably the one of the main ones used worldwide, uses 5 millimeters to increase sensitivity. The ACR used a 7 millimeter because they wanted to increase the specificity. Certainly, the lower cutoffs can create challenges due to other causes of pancreatic duct dilatation. This one is one that I think was a centimeter, so this one you certainly worry about. This was a main duct IPMN. And in the past, years ago, we would just say, oh, the duct's dilated, next case. But now I'm starting to suggest that these could be main duct IPMNs and say that in my reports. This was a case that I learned a lot from. This was actually a 70-year-old physician, a 79-year-old physician. It was a radiologist who was still practicing, was friendly with a guy, had a branch duct IPMN. It was about 3 centimeters. Given his age, and certainly with the ACR guidelines, you could say you're going to stop following it. Thankfully, he came into the hospital because he had some vague abdominal pain, and this was about 10 years ago. So you can tell he's been alive for over 10 years. But what do we see here? We see the cyst looks the same, but what do we see instead? We see the abrupt terminating duct sign. That's one of my favorite signs. If I see an abrupt terminating duct sign, you have to worry about it being due to an underlying cancer. And we have seen this multiple times. It's where you can make a difference. You can potentially detect pancreatic cancer early, which is like unheard of. I mean, I think it's more important for us to be able to detect cancer early, obviously, than to stage the cancer, because we want to find that. So needless to say, at this point, I said, get an EUS, get a biopsy, make sure there's not an underlying cancer. I'm highly suspicious, but I know a lot more than I used to know. And that was based on a Mayo Clinic article by Dr. Gainji and J.G. Fletcher, where they reported anywhere from 6 months to a year and a half before the diagnosis of pancreatic cancer, you can often see features suggestive of cancer, including this abrupt terminating duct sign. So anyway, he had the MR, and if you look closely, you might suggest a mass. There's certainly features suspicious for a mass, but more importantly, he got the EUS, got the biopsy, got it resected, and as I mentioned, he's already alive 10 years later. So what does this illustrate? This illustrates something that I wasn't aware of years ago. This is referred to as the field defect, and that's where patients with IPMNs are prone to pancreatic cancer elsewhere in the pancreas separate from the cyst. It's analogous, in my opinion, to cirrhosis leading to HCC, or maybe esophageal dysplasia and Barrett's leading to esophageal cancer. So patients that have these IPMNs are going to develop cancer. And as I said, the age cutoff may be controversial because he's 79 at diagnosis and he's still alive. But removing that pancreatic head cyst really wouldn't have made a difference. He still would have gotten the pancreatic cancer. So this field defect, as I mentioned, is seen in branch duct and main duct IPMNs, and it may be a harbinger of a background parenchyma abnormality leading to cancer. And it certainly mitigates the ability to predict cancer based on what I talked about before, those worrisome features and high-risk stigmata, because it can be seen in patients without those features, as I'll show you as well. A few articles. These were used, I think, for emphasizing, following these patients. So this article said that pancreatic cancer in branch duct IPMNs occurred more frequently in older patients than in women. Another article showed that pancreatic cysts increased the mortality and increased the risk of pancreatic cancer. And I think this is one of the articles that motivated the ACR guidelines. They used to do a 1-year follow-up, and now they're recommending 10-year follow-up. So it does illustrate that a lot of times we just don't know what we should be doing. Multiple studies showed that there's increased prevalence of synchronous and metachronous cancers developing and following these patients. 5-year follow-up, these patients developed 7% and an incidence of about 1% a year. This article actually says you shouldn't stop surveillance at 5 years, as I'll show you. Some of the guidelines suggested stopping at 5 years, but in this particular article, 5-year stability, in fact, didn't mean that the patient wasn't going to get cancer, and the patients had a 3-fold increased risk of cancer compared to the general population. This was I used to show this in my talks as a serous cystadenoma. I think in retrospect, it probably was a branch duct IPMN, but the reason I show this is because you just don't want to focus just on the cystic lesion, which was what they had done on the CT scan. When we did the MR, what did we find? We found a subtle pancreatic cancer in the uncinate. So this probably was a branch duct IPMN associated with a cancer. This was a patient that we were following, a 7-year-old female, had a cystic lesion, looks innocuous, but then when they came for follow-up, the other cystic lesion actually developed a mural nodule. Given the mural nodule, we said it was suspicious, and it turned out to be cancer. But it does illustrate how subtle they can be. So these are the guidelines. I don't expect you to memorize these, but I do want to illustrate them because that's what our referring physicians utilize. There's the AGA guidelines, the international consensus that I referred to, Fukioka guidelines, ACR guidelines, obviously from us, American College of Gastroenterology, and the European Study Group. It's almost like a Tower of Babel. Every guideline has a little bit different target population, Some look at clinical symptoms, some look at the size of the cyst, and the recommendations and the timing of the follow-up all vary, highlight slightly different features associated with malignancy. So again, this is in the article that I wrote about, but it does illustrate a lot of them look at the worrisome features of size over 3 centimeters, a main pancreatic duct dilatation. If there's non-enhancing nodules, then they're more likely worrisome features. High-risk stigmata, as we mentioned, was if the main pancreatic duct is markedly dilated or if you have a solid enhancing nodule. Similarly, they're all over the place as far as the extent of follow-up, the length of follow-up, the time of follow-up. Some look at actual size of lesions, others do not. And then it's interesting, if you look at the follow-up period, this was one of the earlier guidelines, said 5 years. Now you can see that a bunch are recommending lifelong surveillance. The ACR, it depends on the age and it depends on the size as well. And as I mentioned, some look at worrisome features and high-risk stigmata, and others look at when do we do intervention, when do we do EUS or do surgery. Oops. So the ACR guidelines, certainly a good resource that we should look at. They talked about the field defect. They talked about these very small cysts. They refer to them as white dots and suggested following them for 2 years, and then you could stop following them. And again, it ended at 10 years or after age 80. They're, in fact, trying to develop some global consensus guidelines, which I certainly am supporting and interested in getting involved with, because I think that'll make things easier. So again, guidelines I think are important for consistency. I think you should work with your key stakeholders at your own institution, whether they're the gastroenterologists, pancreatologists, and surgeons, to see which guidelines you should follow or modify them for your institution, as we had done, as I'll talk about. I used to not be a big fan of standardized reporting, but I've become a huge fan of it because I think it ensures uniformity of our interpretations, especially as a lot of healthcare systems get a lot larger and there's a lot of referring doctors that you may or may not know. And it's alleviated a lot of the questions where people used to call me because I wouldn't give guidelines. But some of the questions you got to certainly consider are the size of the cysts, and if you want more or less frequent surveillance, longer duration if you want an age dependency, and what is the role of EUS, and certainly sampling. So here's kind of a scary case. This was a 61-year-old female. We were following the patient, had a really tiny cyst, a few millimeters in diameter. A year later, it became nearly imperceptible. You could argue you're going to stop following it. Nevertheless, she got a 1-year follow-up after this image. And what happened then? Unfortunately, she had a pancreatic cancer that was involving the jejunal branches and was unresectable on the follow-up. It illustrates potentially the field defect, and it certainly illustrates that cancers don't follow the rules. They're not going to wait to our follow-up interval, whatever we decide upon. Unfortunately, and this really upset the gastroenterologist as well because he was following the patient closely. As I mentioned, what are the challenges with surveillance? We're not sure that screening all patients with pancreatic cysts will prove efficacious given the large number of patients with cysts and this very small percentage that will develop into cancer. Certainly extremely costly to patients and the healthcare system. We don't have ideal markers to tell which patients with cysts will develop cancer in the cysts or in the remainder of the pancreas. What about abbreviated protocols? Well, you can certainly make the argument that you should do abbreviated protocols given the large number of pancreatic cysts and the potential lifelong surveillance. You could do a short limited protocol with MR and not give gadolinium, do it as a non-contrast, and certainly enticing. There's studies that certainly have shown no benefit of the cyst assessment with the addition of GAD, so it avoids the long-term effect of gadolinium retention. It can save time and cost. The problem is, in my opinion, it remains unclear of how good we're going to be with these short non-contrast protocols in cancer detection, because some of these patients will have very heterogeneous pancreases, hard to assess, and cancer sometimes can be subtle and challenging in patients with chronic pancreatitis. So at this point, at least until there's more guidance, we continue to use contrast, but I certainly I think it's potentially appropriate not to give contrast. So in conclusion, I think radiologists can diagnose many of these pancreatic cystic lesions, triaging those that need follow-up versus surgery. I also think it's important to develop appropriate guidelines at your institution to allow consistency in reporting. As I mentioned, the field defect is something new to me over the last few years, and it certainly complicates our assessment. And certainly, I think the guidelines will be evolving as additional scientific information becomes available. And hopefully, I didn't add to your misery by giving you this lecture, but there's a lot of uncertainty certainly as well. Thank you.